Colleagues, welcome. We are accustomed to diagnostic clarity in our respective practices. We rely on, definitive imaging, absolute biomarker thresholds, and binary clinical determinations.
Right, the standard binary of healthy versus diseased.
Exactly. But as we increasingly navigate the complexities of geriatric endocrinology, we find ourselves operating in the rather muddy waters of metabolic stagnation. I mean, we face a diagnostic landscape where insulin sensitivity degrades insidiously.
And it often presents long before our standard HbA1c or fasting glucose panels trigger any sort of clinical alarm.
Precisely. So today's deep dive examines a non-pharmacological protocol that fundamentally challenges our reliance on chemical interventions for early-stage metabolic syndrome. We will be rigorously evaluating classified clinical data detailing the failure of insulin signaling in aging populations.
Alongside an intervention demonstrating, well, substantial systemic recalibration.
Yes. Specifically, we are analyzing Dr. Francisco Vasquez's data on a targeted 2 to 5 minute postprandial ambulatory protocol. The data suggests this microscopic intervention can attenuate glycemic excursions by 30 to 40%.
And the statistical significance of a 40% reduction, I mean, it cannot be overstated, particularly when we benchmark it against our current standard of care.
Right. We're looking at a zero-cost, mechanically driven intervention.
Exactly. One that, in specific patient cohorts, closely mimics the postprandial glycemic blunting we typically associate with aggressive pharmacological management. But, without the hepatotoxicity or the gastrointestinal distress frequently seen with metformin or GLP-1 receptor agonists.
Which is a profound clinical shift. However, to critically evaluate the efficacy of this ambulatory protocol, we must first establish the precise pathophysiological baseline of the demographic in question.
We are focusing on patients over the age of 50, a cohort where we observe a predictable and progressive degradation in the insulin signaling cascade.
Let us trace that degradation sequentially. I mean, we understand the normative physiological cascade following macronutrient ingestion.
The breakdown of complex carbohydrates, the subsequent elevation of serum glucose,
and the biphasic insulin response from the pancreatic beta cells.
Yeah.
But the source material highlights a critical shift at the cellular level as patients cross into their 6th decade.
Right. We move away from normative endocrine function and into a state of structural insulin resistance.
And I want us to drill down into the exact mechanisms of this cellular degradation. It is not merely a decrease in insulin production, is it? It is an occlusion of the receptor site itself.
Precisely. We must look at the insulin receptor substrate, specifically IRS1. In a healthy physiological state, insulin binds to the extracellular alpha subunit of the receptor,
which then triggers the autophosphorylation of tyrosine residues on the intracellular beta subunit.
Exactly. And this tyrosine phosphorylation is the critical catalyst that eventually leads to the translocation of glucose transporters to the cell membrane. However, in our aging demographic, this pathway becomes profoundly compromised by, oxidative stress and chronic low-grade inflammation.
So instead of the necessary tyrosine phosphorylation, we see a pathological increase in serine and threonine phosphorylation on the IRS1 molecule.
Right, and that serine phosphorylation effectively creates a steric hindrance. It fundamentally blocks the downstream signaling cascade.
To utilize a somewhat crude structural analogy, the cellular locks are not just rusting. They're being actively jammed from the inside by inflammatory byproducts.
That is a highly accurate representation of the molecular blockade. The insulin molecule arrives, it successfully docks at the receptor, but the intracellular translation of that signal fails.
The pathway is completely severed.
Yes, and the beta cells of the pancreas, detecting the persistently elevated serum glucose through their own GLUT2 transporters, they interpret this as a failure of volume rather than a failure of receptor sensitivity.
Which leads to the resulting compensatory mechanism, which is severe hypersecretion of insulin. The system floods with the hormone in a desperate, ultimately maladaptive attempt to overcome the peripheral resistance.
Which introduces the primary clinical danger here, which is hyperinsulinemia. We are essentially looking at a state where the body is locked into a chronic anabolic drive.
Right, because when insulin levels remain perpetually elevated, the suppression of hormone-sensitive lipase prevents lipolysis.
While lipogenic pathways in the liver are heavily upregulated, the surplus metabolic energy, the glucose that cannot enter the skeletal muscle due to the jammed IRS1 pathways, it must be diverted.
And its primary diversion route is ectopic fat deposition, specifically targeting visceral adipose tissue.
Correct. The portal circulation becomes inundated with free fatty acids. The body preferentially stores this excess energy in the omentum and mesenteric depots.
Literally physically encapsulating the liver, the pancreas, and the intestinal tract. Now, I must interject here to challenge the causality modeled in some of our foundational literature.
Please do.
We observe the hyperinsulinemia, and we observe the visceral adiposity. But does the data we are reviewing support the lipid overflow hypothesis, where the hypersecretion drives the adiposity? Or is it the accumulation of the visceral fat that primarily drives the systemic resistance?
That is the pivotal question. Are we fundamentally treating a primary hyperinsulinemia or a primary adiposopathy?
Exactly. What does the clinical data from Dr. Vasquez's analysis suggest?
It suggests it is a highly integrated pathological feedback loop, but the visceral adiposity rapidly shifts from being a storage symptom to a primary causative agent of further decline.
Because visceral adipose tissue is not a metabolically inert storage depot.
Not at all. It is a highly active endocrine organ. As the adipocytes hypertrophy, they essentially outgrow their local vascular supply.
Leading to hypoxia and cellular necrosis.
Precisely. And this necrotic environment triggers a massive infiltration of macrophages, which polarize into the pro-inflammatory M1 phenotype.
Resulting in a localized cytokine storm.
Exactly. These M1 macrophages begin secreting massive quantities of inflammatory cytokines, notably TNF-alpha and interleukin-6, directly into the portal vein.
Which then travel to the liver and skeletal muscle.
Right, where they activate inflammatory kinase pathways like JNK and IKK-beta. And what do those kinases do? They directly catalyze the pathological serine phosphorylation of IRS1 that we just discussed.
So the very tissue created by the insulin resistance actively secretes the localized hormones that exacerbate the resistance.
The systemic degradation accelerates exponentially. This explains why our geriatric patients often present with, rapidly expanding waist circumferences and deteriorating HbA1c levels, despite reporting absolute caloric stagnation.
The internal metabolic math has been entirely rewritten by this inflammatory loop.
What underscores the profound danger of the default behavioral phenotype we observe in modern aging populations.
Right. Consider the physiological state of a 60-year-old patient immediately following a substantial carbohydrate load.
They are experiencing a maximum serum glucose surge. Their compromised beta cells are hypersecreting insulin into a highly resistant periphery.
And their behavioral response is almost uniformly to assume a supine or seated sedentary position.
By remaining sedentary postprandially, the patient effectively shuts down the metabolic demand of the skeletal muscle system, which is the body's primary glucose sink.
They are relying entirely on a broken endocrine pathway to clear a massive chemical load. The glucose is subsequently shunted through de novo lipogenesis directly into that inflammatory visceral tissue.
It is, quite frankly, the absolute worst possible behavioral input during the most metabolically vulnerable window of the circadian cycle.
However, this is precisely where the clinical data provides a paradigm shift, because while the insulin-dependent pathway via IRS1 and PI3K is structurally compromised,
the skeletal muscle possesses an entirely distinct mechanical pathway for glucose clearance that bypasses the endocrine system entirely.
let us examine this secondary pathway meticulously. We are shifting our focus to the mechanical translocation of glucose transporter type 4, or GLUT4.
Right. The literature establishes that while GLUT4 translocation is typically modulated by insulin, it can be stimulated independently through muscular contraction.
How exactly does this mechanotransduction bypass the pathological serine phosphorylation we just detailed? I want to make sure we map out the exact cellular cascade.
The skeletal muscle has evolved redundant pathways to ensure energy availability during acute physical stress. It's a vital evolutionary adaptation for the fight-or-flight response.
Right.
When a muscle fiber contracts, it initiates a cascade of intracellular events that are completely decoupled from the insulin receptor. Firstly, the release of calcium ions from the sarcoplasmic reticulum directly activates calcium calmodulin-dependent protein kinase, or KMK.
Secondly, the physical mechanical stress and the immediate consumption of ATP elevate the AMP to ATP ratio within the cell,
which serves as the primary trigger for AMPK-AMP-activated protein kinase. Correct. The activation of both CAMK and AMPK converges on the intracellular vesicles storing the GLUT4 transporters.
Concurrently, the mechanical stretching of the muscle fibers activates RAC1, a GT pace.
Yes, and together, these mechanical and energetic signals force the GLUT4 vesicles to translocate from the deep intracellular matrix to the sarcolemma, where they fuse and open to the extracellular space.
And this entire process occurs without a single molecule of insulin docking at a receptor site. The locked doors are bypassed because a completely different set of doors has been forcefully opened from the inside.
Precisely. The mechanical contraction renders the oxidized, inflamed state of the insulin receptors entirely irrelevant for the duration of the physical activity.
The source data utilizes an excellent biomechanical analogy to illustrate this phenomenon on a macroscopic tissue level, referring to the myocellular structure as a hydraulic sponge system.
It's a brilliant conceptualization. Let's expand on the fluid dynamics of that hydraulic model as it clarifies the interstitial exchange perfectly.
When the patient is seated, the skeletal muscles of the lower extremities are under constant static compression.
Right. The hydrostatic pressure within the interstitium is stabilized, and capillary perfusion is functioning at baseline maintenance levels. The sponges are metabolically inert and physically compressed.
Yes, and without that physical expansion, the concentration gradients required for rapid glucose uptake are completely absent.
But upon the initiation of ambulation, specifically rhythmic, low-intensity contraction of the soleus, gastrocnemius, and quadriceps, the physical architecture of the tissue changes fundamentally.
The cyclical shortening and lengthening of the sarcomeres literally squeeze the interstitial space.
You compress the tissue, forcing out metabolic byproducts, and then, during the relaxation phase of the stride, the tissue expands, creating a transient drop in local hydrostatic pressure.
This physical expansion, combined with the mechanically translocated GLUT4 receptors on the sarcolemma, creates a literal vacuum effect.
Exactly. It draws glucose-rich plasma from the capillary beds directly into the intracellular space. It is a profound shift in the hemodynamic and metabolic landscape.
And the downstream systemic endocrine relief is immediate, isn't it?
Very much so. By mechanically siphoning the glucose from the serum, the initial hyperglycemic trigger is dramatically blunted.
The beta cells, sensing the stabilization of serum glucose via their GLUT2 transporters, immediately downregulate insulin secretion.
Therefore, the hyperinsulinemia is averted. The hormonal signal that drives de novo lipogenesis in the liver is suppressed.
By simply turning on the muscular vacuum, we intercept the metabolic surplus before it can be partitioned into the visceral adipose tissue.
We are effectively short-circuiting the inflammatory feedback loop we established earlier. However, the efficacy of this mechanical bypass is strictly governed by its pharmacokinetics.
Right. A mechanism is only clinically relevant if it is deployed at the correct chronological point in the physiological cascade.
Exactly. Which brings us to the rigid parameters of the clinical intervention. We must align the muscular contraction with the precise pharmacokinetic peak of postprandial glucose.
The data is unequivocal regarding the timing. Let us evaluate the standard glycemic curve following a mixed macronutrient meal.
We must account for the rates of gastric emptying and intestinal absorption. While the liquid phase of a meal empties rapidly, the solid phase requires mechanical breakdown in the antrum.
Generally, the initial wave of glucose breaches the intestinal mucosa and enters the portal circulation between 15 and 30 minutes post-ingestion.
Driven partially by the incretin effect, the release of GLP-1 and GIP from the enteroendocrine cells, which primes the pancreas even before the serum glucose formally rises.
Correct. The glycemic curve continues to steepen, typically reaching maximum serum concentration, or Cmax, between 60 and 90 minutes postprandially.
And this 60 to 90-minute window represents the apex of endocrine stress. It is the moment of maximum insulin resistance and peak hyperinsulinemic response.
The source data strictly defines the golden window for intervention as the immediate postprandial period. The ambulatory protocol must be initiated within the first 15 minutes following meal cessation.
If the muscular contraction begins before the 15-minute mark, the GLUT4 receptors are fully translocated, and the hydraulic vacuum is active precisely as the primary wave of glucose enters the systemic circulation.
The glucose is cleared continuously, flattening the area under the curve, or AUC, for that specific meal.
The clinical efficacy metric demonstrated in the source data is a 30 to 40% reduction in the glycemic spike compared to a sedentary control.
I want to critically evaluate that number. If we compare a 40% reduction mathematically to standard pharmacological interventions in this demographic, say a 1,000 milligram daily dose of metformin, how does this mechanical intervention hold up?
It is highly competitive. Metformin primarily works by suppressing hepatic gluconeogenesis and modestly enhancing peripheral sensitivity.
Often yielding a 1.2 to 1.5% reduction in absolute HbA1c over months.
Right. But a 40% acute blunting of postprandial excursions, repeated 3 times daily, radically reduces the cumulative daily glycemic load.
Over a 90-day period, the aggregate reduction in advanced glycation end products and endothelial stress is mathematically comparable, if not superior, to monotherapy with standard oral hypoglycemics.
Let us examine the specific case study provided in the source material to ground these metrics.
The subject is a 58-year-old retired patient presenting with a fasting serum glucose of 108 milligrams per deciliter, indicating entrenched hepatic insulin resistance.
A classic pre-diabetic presentation. Furthermore, the patient exhibited progressive increases in waist circumference despite reported caloric stagnation.
Confirming the lipid overflow into visceral depots, and notably they reported severe postprandial somnolence.
That somnolence is an often overlooked clinical marker. It represents a state of severe autonomic dysregulation.
The parasympathetic nervous system and the endocrine system are so overwhelmed by the hyperglycemic and hyperinsulinemic load that cerebral perfusion and baseline alertness are compromised.
The body essentially enforces a systemic shutdown to manage the metabolic crisis.
The clinical intervention applied was remarkably minimalist. 3 minutes of low-intensity ambulation immediately following primary meals. No alteration to baseline caloric intake or macronutrient composition was mandated.
And the longitudinal results are highly instructive. At week 4, the patient reported total eradication of the postprandial somnolence,
which confirms immediate, acute blunting of the glycemic excursions. The autonomic nervous system was no longer being forced into crisis management.
By week 8, morphological changes were documented, specifically a reduction in waist circumference,
indicating a halt to visceral lipogenesis and a potential initiation of lipolysis in those depots.
And at the 90-day mark, the fasting serum glucose had normalized from 108 down to 94 milligrams per deciliter.
That 90-day metric is crucial because it indicates a systemic recalibration of hepatic insulin sensitivity.
By preventing the daily postprandial spikes, the liver was no longer subjected to the constant hyperinsulinemic signaling, allowing it to downregulate its own gluconeogenic output during the fasting state.
But this requires a critical challenge regarding patient execution. I frequently encounter patients who attempt to consolidate their daily movement.
Yes.
They will consume a heavy, midday meal, return to their desk for 2 hours, and then execute a vigorous 45-minute walk. They believe the total caloric expenditure compensates for the meal.
It's a very common clinical misconception.
If a patient walks 120 minutes post-meal, what is the exact metabolic failure of that delayed intervention?
The failure lies in a fundamental misunderstanding of pharmacokinetics. By minute 120, the glycemic spike has already peaked and is likely on its descent.
The area under the curve has been fully realized.
Precisely. The pancreas has already detected the Cmax, it has already secreted the massive compensatory wave of insulin, and that insulin has already instructed the hepatic tissue to convert the surplus glucose into free fatty acids.
The pathological signaling cascade is complete.
Exactly. A walk at 2 hours maintains general cardiovascular benefit. It enhances stroke volume, maintains endothelial nitric oxide production, and supports muscular endurance.
But it has entirely lost its targeted efficacy as a metabolic interceptor for that specific macronutrient load.
The GLUT4 activation is occurring in a serum environment where the primary threat has already been metabolized into inflammatory adipose tissue.
So to blunt the spike, the mechanical vacuum must be active concurrently with the intestinal absorption phase.
The timing is non-negotiable, which leads us to the specific physiological parameters of the movement itself.
Right. While the timing must be acute, the physical intensity of the intervention must remain remarkably low. The source characterizes the required exertion as a market-pace stroll, a steady-state, highly submaximal ambulatory cadence.
Exceeding this submaximal threshold introduces catastrophic physiological cross-signaling, which we will dissect when we discuss clinical contraindications.
But at this mild intensity, the protocol introduces 2 vital autonomic synergies that compound the metabolic benefit: exclusive nasal respiration and orthostatic alignment.
Let us evaluate the neurobiology of the respiratory constraint first. Instructing a patient to breathe exclusively through the nares during the postprandial ambulation is an explicit intervention targeting the vagus nerve.
The polyvagal implications here are substantial. The postprandial state requires profound parasympathetic dominance to optimize gastric motility, enzyme secretion, and intestinal blood flow.
Right. The vagus nerve, serving as the primary parasympathetic efferent pathway, releases acetylcholine at the gastric and pancreatic ganglia.
Mouth breathing, biomechanically and evolutionarily, is coupled with sympathetic arousal, the anticipation of high exertion or distress.
By enforcing nasal respiration, we optimize the production of nitric oxide in the paranasal sinuses, which acts as a potent systemic vasodilator.
More importantly, the increased nasal airway resistance slows the respiratory rate, directly stimulating the vagal afferents.
We are artificially upregulating the parasympathetic tone while simultaneously engaging in skeletal muscle contraction.
We are sending a definitive neurological signal that the body is in a state of safety and digestion, despite the ongoing mechanical work.
This optimizes the release of pancreatic polypeptide and ensures the splanchnic circulation remains fully perfused.
Which integrates seamlessly with the second required synergy,
Mm-hmm.
orthostatic alignment. The biomechanics of an erect posture, scapular retraction, thoracic extension, and a neutral cervical spine are frequently dismissed in metabolic discussions, but their impact on internal hemodynamics is measurable.
When a patient adopts a kyphotic, slouched posture, the standard phenotype of a patient walking while observing a mobile device, they physically compress the thoracic cavity.
This compression limits the excursion of the diaphragm.
If the diaphragmatic excursion is limited, intrathoracic pressure dynamics are compromised. This not only decreases total tidal volume, but impairs the venous return to the right atrium, as the respiratory pump mechanism is blunted.
Furthermore, the restriction in tidal volume reduces the alveolar oxygen tension. The skeletal muscles, actively vacuuming glucose via the GLUT4 pathways, require optimal oxygen saturation to efficiently process that substrate through oxidative phosphorylation in the mitochondria.
Right. If the patient is hypoxic due to postural collapse, the myocellular furnace is operating at a profound deficit.
The source explicitly notes that a 3-minute period of ambulation with optimal orthostatic alignment and nasal respiration yields exponentially greater clinical value than 10 minutes of slouched, sympathetically driven movement.
We are optimizing the oxygen extraction ratio, the AVO2 difference, at the tissue level.
We are marrying the mechanical opening of the cellular doors with the exact autonomic and respiratory conditions required to metabolize the substrate efficiently.
However, any intervention that directly manipulates hemodynamics, autonomic tone, and serum glucose levels carries explicit clinical risk.
We must conduct a rigorous review of the contraindications and physiological air modes that can render this protocol either ineffective or acutely dangerous for the geriatric demographic.
Absolutely. The simplicity of the intervention does not negate its potency. We must stratify the clinical risks, beginning with red flags for immediate cessation.
The primary indicators of acute distress during this protocol are well established. Any manifestation of angina pectoris, compressive thoracic discomfort radiating to the mandible, neck, or upper extremities requires immediate termination of the ambulation.
This indicates myocardial oxygen demand has outstripped coronary supply, an acute ischemic event entirely independent of the digestive process.
We must also instruct patients to halt if they experience severe vertigo, unexplained diaphoresis, visual field disturbances, or dyspnea that is mathematically disproportionate to the minimal exertion of a market-paced stroll.
The source also flags acute abdominal pain, particularly localized to the right upper quadrant or radiating dorsally, which could indicate biliary colic triggered by the gastric load.
And unilateral lower extremity edema, or erythema, the classic presentation of deep vein thrombosis.
These are universal criteria for emergent medical evaluation, but the more insidious risks lie in pharmacological interactions.
Geriatric cohorts present with significant polypharmacy, and manipulating postprandial glucose clearance can dramatically alter established pharmacodynamics.
The most critical interaction involves exogenous insulin administration or the use of insulin secretagogues, such as sulfonylureas like glipizide or glimepiride.
The clinical danger here is profound. When an endocrinologist titrates a dosage of fast-acting prandial insulin, that calculation is predicated on a specific absorption curve and a baseline assumption of postprandial sedentary behavior.
The physician has mathematically modeled the chemical clearance required for a patient sitting in a chair.
Precisely. If the patient suddenly introduces this targeted ambulatory protocol, they're activating a massive secondary mechanical clearance pathway simultaneously.
The GLUT4 translocation, combined with the exogenous insulin, creates a synergistic glucose sink. The risk of acute, severe hypoglycemia is extreme.
The serum glucose could crash rapidly, leading to neuroglycopenia, syncope, or worse.
Any patient utilizing exogenous insulin or secretagogues must execute strict pre- and post-ambulation capillary glucose monitoring.
And their prescribing physicians must proactively titrate their dosages downward to account for the mechanical clearance.
The second pharmacological interaction of note involves antihypertensive agents.
Beta blockers, ACE inhibitors, and calcium channel blockers actively suppress the normal sympathetic baroreceptor reflex.
When a patient transitions from a seated postprandial state where blood is heavily pooled in the splanchnic bed to a standing position, gravity dictates a sudden drop in venous return to the brain.
Normally, the body triggers rapid, transient vasoconstriction to maintain cerebral perfusion.
But the antihypertensives block this compensatory vasoconstriction. The patient is at high risk for orthostatic hypotension, potentially leading to syncope and fall-related trauma.
Which carries a high morbidity in the over 50 population. The clinical instruction must be a heavily protracted, staged transition from seated to standing prior to initiating the ambulation.
We must also account for structural and systemic limitations. Patients with advanced osteoarthritis of the hip or knee, severe diabetic peripheral neuropathy, active oncology protocols inducing severe cachexia, or end-stage renal disease
May find 3 minutes of continuous ambulation structurally damaging or systemically overwhelming.
The intervention must be aggressively scaled in these populations. The physiological principle of mechanical contraction remains valid even at microscopic volumes.
1 minute of highly assisted ambulation, utilizing a walker or remaining adjacent to a supportive structure, still provides measurable GLUT4 activation without inducing severe fatigue or structural degradation.
This transitions us directly into the analysis of patient error modes. Specifically, how metabolically healthy patients completely nullify the clinical benefits of this protocol through improper execution.
The most prominent error directly addresses the misconception that higher exertion yields greater metabolic clearance. The data shows that increasing the intensity triggers a physiological phenomenon known as hemodynamic shunting.
This is a critical failure of physiological prioritization. During the immediate postprandial phase, the autonomic nervous system directs a massive volume of cardiac output to the splanchnic circulation.
The superior and inferior mesenteric arteries are fully dilated to facilitate nutrient absorption and transport via the portal vein.
The gastrointestinal tract requires optimal perfusion to execute its function. But what occurs if the patient decides to elevate the intensity of their walk?
They transition from a market-pace stroll to a vigorous power walk or light jog, elevating their heart rate and inducing perspiration.
The cerebral cortex registers the increased mechanical load and shifts autonomic priority. The sympathetic nervous system overrides the parasympathetic digestive state.
The body interprets the high-intensity movement as a need for fight-or-flight resources. It aggressively vasoconstricts the mesenteric vascular beds and vasodilates the arterioles supplying the somatic musculature.
It effectively steals the blood supply from the digestive tract and shunts it to the peripheral skeletal muscles.
This abrupt ischemia in the gut halts the digestive process entirely. The clinical manifestations are immediate: severe dyspepsia, acute gastrointestinal cramping, gastroesophageal reflux, and reflex tachycardia.
As the heart struggles to simultaneously perfuse both the highly demanding somatic muscles and the engorged yet restricted splanchnic bed.
The attempt to maximize the caloric burn actively destroys the precise metabolic environment required for the GLUT4 intervention to succeed. The intensity must remain below the threshold of sympathetic override.
A second critical error mode involves the mathematical fallacy of utilizing the protocol to offset high glycemic loads.
Right. The 30 to 40% reduction in glycemic excursion is a relative percentage, not an absolute barrier.
If a patient consumes a mathematically overwhelming load of hyper-processed acellular carbohydrates, such as industrial fructose syrups, heavily refined starches, or substantial volumes of ethanol, the baseline serum glucose spike reaches pathological extremes.
If the baseline spike represents a catastrophic endocrine event, a 40% reduction still leaves the patient in a state of severe hypoglycemia and hyperinsulinemia.
The protocol is an optimization tool for a standard, balanced macronutrient load. It does not possess the pharmacokinetic power to neutralize extreme dietary negligence.
Finally, we observed the failure of inconsistency. The cellular architecture of the insulin receptor and the surrounding adipose tissue adapts to chronic environmental pressures, not acute, isolated events.
The reversal of serine phosphorylation on the IRS-1 molecule requires a sustained daily reduction in localized inflammation. Executing the protocol sporadically fails to alter the long-term endocrine trajectory.
Which brings us to the operational reality of geriatric medicine. Behavioral compliance. We possess this highly efficacious, zero-cost mechanical intervention.
But standard medical directives simply instructing a patient to walk after meals yield notoriously low long-term adherence.
To bypass the psychological friction and ensure autonomic habituation, the clinical data provides a rigid 7-day titration protocol. We must analyze the neurobiology behind this titration. Why segment the implementation into a 7-day ramp-up?
The protocol is designed to circumvent the high activation energy required to initiate a new movement pattern. The geriatric brain, conditioned by decades of postprandial sedentary behavior, perceives traditional exercise as a high-friction event requiring planning, transport, and physical discomfort.
The basal ganglia have hardwired the meal completion to couch loop.
Day 1 of the protocol directly attacks this friction by mandating a strict 2-minute duration following only the primary caloric load of the day. The instruction is explicit, no more than 2 minutes.
This artificially low ceiling is a psychological tool. It eliminates all perceived barriers to entry. No patient can rationally claim they lack the physical stamina or time to stand for 120 seconds.
The source data also advises coupling this initial movement with a hydration routine, sipping water during the ambulation.
This serves a dual purpose. Physiologically, it aids gastric motility. Neurologically, it provides a secondary familiar task that distracts from the novelty of the movement, making the behavior feel less like a clinical prescription and more like a natural extension of the meal.
By day 2, the primary post-meal 2-minute walk is maintained, and a 1-minute post-breakfast walk is introduced, provided the breakfast is carbohydrate inclusive.
We are initiating the repetition necessary for neuroplasticity. We are beginning to rewrite the basal ganglia circuitry.
Day 3 dictates an increase to 3 minutes post-primary meal and 1 minute post-breakfast. The critical clinical marker for day 3 is monitoring for a subjective reduction in postprandial somnolence.
This is the inflection point of compliance. When the patient subjectively registers the absence of the typical autonomic crash, when they realize they possess systemic energy following a heavy meal, dopaminergic pathways are activated.
The behavior shifts from being externally mandated by a physician to being intrinsically motivated by positive physiological feedback.
They associate the mechanical contraction with feeling demonstrably better. Day 4 is when we introduce the autonomic constraints we discussed previously, the exclusive nasal respiration and the orthostatic postural alignment.
We delay this instruction until day 4 to prevent cognitive overload during the initial habituation phase. Once the physical act of rising post-meal is somewhat established, we refine the biomechanics to maximize vagal tone and diaphragmatic excursion.
Day 5 is designated as consolidation. The protocol scales to a full 3 minutes following every major caloric intake event.
The physical pathway is now aggressively reinforcing the neurological habit. The completion of mastication and swallowing begins to act as an automatic physiological trigger for skeletal muscle activation.
Day 6 introduces an entirely new physiological variable, circadian regulation. The directive is to transition at least one of the ambulatory sessions to an exterior outdoor environment. We must evaluate the clinical literature supporting this environmental shift.
The integration of natural sunlight into the postprandial window is a powerful metabolic synergist. When full-spectrum natural light stimulates the melanopsin-containing retinal ganglion cells in the eye, it sends a direct, unmediated signal via the retinohypothalamic tract to the suprachiasmatic nucleus.
The suprachiasmatic nucleus functions as the master circadian clock of the brain, directly regulating peripheral clocks throughout the body, including those in the liver, pancreas, and skeletal muscle.
Clinical data clearly demonstrates that circadian entrainment via optic light exposure directly influences the expression of PER and CRY genes in peripheral tissues, which in turn modulates insulin sensitivity and glucose tolerance.
By syncing the mechanical clearance of glucose with acute circadian light signaling, we are optimizing the entire endocrine cascade at a molecular level.
We are leveraging evolutionary biology, informing the brain that metabolism should be highly active. Finally, day 7 represents total integration.
The seamless automatic application of 2 to 5 minutes of targeted low-intensity ambulation following every meal, executed with proper autonomic form and optimal timing.
At this stage, the activation energy is negligible. The protocol proves that the restoration of metabolic health in aging populations does not necessitate high-impact, sympathetically dominant exercise regimens.
The preservation of cellular insulin sensitivity is governed by highly specific, repetitive, low-impact physiological cues.
It is the compounding efficacy of the microintervention. 3 minutes, 3 times daily, equates to merely 9 minutes of total mechanical work.
But because those 9 minutes are deployed precisely during the pharmacokinetic peak of the postprandial state, they possess the leverage to rewrite the body's systemic metabolic trajectory.
It is a targeted strike on the underlying pathophysiology of early-stage metabolic syndrome.
Colleagues, to summarize the critical clinical takeaways from our analysis today, we must acknowledge that structural insulin resistance and the degradation of the IRS-1 pathway are pervasive realities in our aging cohorts.
This failure directly drives the hyperinsulinemic feedback loop, resulting in the accumulation of inflammatory visceral adipose tissue and the acceleration of systemic metabolic decline.
However, the data confirms that the skeletal muscle possesses a robust, redundant mechanical pathway for glucose clearance.
By utilizing 2 to 5 minutes of low-intensity postprandial ambulation, we induce the mechanical translocation of GLUT4 receptors to the sarcolemma.
This physical vacuum extracts serum glucose entirely independent of the compromised endocrine pathways, safely attenuating glycemic excursions by up to 40% and directly halting the lipogenic drive that creates visceral fat.
This efficacy is strictly dependent on exact pharmacokinetic timing, initiating the movement within 15 minutes of meal cessation, and requires a rigid adherence to low-intensity pacing to avoid the catastrophic effects of splanchnic hemodynamic shunting.
This has been a rigorous evaluation of the physiological data. But before we conclude this symposium, I want to pose a forward-looking clinical hypothesis for you to consider as you return to your respective practices.
Indeed. We have established that the mechanical translocation of GLUT4 can effectively bypass oxidized endocrine pathways in peripheral skeletal muscle. But what are the implications of this mechanism when we look beyond the periphery?
Consider the neuromuscular pathways within the central nervous system. We are increasingly recognizing Alzheimer's disease and broader cognitive deterioration as type 3 diabetes, a state of profound, localized insulin resistance within the brain tissue itself.
If a targeted microambulation protocol can systemically lower circulating insulin, reduce systemic inflammatory cytokines, and improve baseline endothelial function, could this exact protocol serve as a frontline non-pharmacological defense against the cerebral insulin resistance driving cognitive decline?
Could the simple act of standing up after a meal be the missing variable in preserving neurological integrity?
It fundamentally challenges us to reconsider how we treat systemic metabolic stagnation across all tissue types.
We thank you, our colleagues, for your rigorous attention during this analysis of the clinical data.
We must continue to evaluate these mechanical pathways with the same scrutiny we apply to our pharmacological tools.
Until our next deep dive, we encourage you to integrate these physiological parameters into your clinical assessments.